Finally, we will hear from Dr. Megan Smith, who will provide an overview of the work from the Moms Partnership. Dr. Smith is an associate professor in the Department of Psychiatry in the Child Studies Center at the Yale School of Medicine and in the Department of Social and Behavioral Sciences in the Yale School of Public Health. She's also the founder and director of the Mental Health Outreach for Mothers, Moms Partnership. The Moms Partnership is a novel, two-generational approach to promote the mental health of overburdened and underserved mothers that began in New Haven, Connecticut. Welcome, Dr. Smith.
Thank you very much. So today I'll be talking about the Moms Partnership for Overburdened Underserved Women and really community-based approach, community-partnered approach to addressing maternal depression. I think given what we've heard so far today, I really wanted to focus on how we think at Moms about a program that is really deeply rooted and undergirded with some of the neurobiological and social behavioral sciences, and what that looks like when it's also community-driven and place-based, and how you specifically think about scaling a program in other areas. That's this. So it really does go back to thinking about the theory of change, thinking about the core programmatic elements, and then also concepts of community-driven nature, a shared set of outcomes, and then per the committee's request, really thinking about some of the challenges and opportunities around scaling this kind of program. So to think about one of the important frames of the Moms Partnership is that when we think about improving child outcomes and really launching children on an upward trajectory of economic and social mobility, really focused on building the capacities and skills of parents, and in particular this case of mothers and female caregivers. And very obsessed with the mediating variables and really understanding those mediators. So as we seek to address maternal depression, and improve these outcomes for children, what are the mechanisms and those core variables that in any kind of scaling and implementation we need to measure and also make sure that we're impacting. And so specifically to this, we really are explicit about an equity frame, and that is part of our theory of change. As was mentioned before, when we think about mental health, we're inherently in an environment of scarcity where we don't have a sufficient supply of mental health clinicians globally, and also where we have increasing racial, ethnic, and income inequities that are growing, unlike other areas of chronic disease. And so given this frame, we think about systematic participation. How do we systematize the participation of, in this case, mothers and female caregivers in an intervention, again, rooted in science? We're focused on behavioral activation. We do that by cognitive behavioral therapy and using and developing cognitive behavioral therapy that's applicable to a low literacy, low numeracy population, and again, a population with very little social capital. We focus on core executive functions and self-regulation for parents, for mothers, and also for their children. And then maternal sensitivity, which is really a key mediating variable that's disrupted in maternal depression and leads to pernicious outcomes for children. Also, akin to that is reflective functioning and reciprocity and synchronicity in the maternal and child relationship. I also want to note that one piece of the equity here that's so critically important is an outcome that also includes social and economic mobility. So we are a mental health program and focused on maternal depression, but given what we've heard from mothers, the economic and the social mobility is just critically important. So we are cognizant of maintaining outcomes that measure those elements of functioning for families and for systems. So I often talk about moms as actually being born out of failure and my own failure as a researcher and health systems change agent in some ways, which, one of the public health approaches that we use largely was around screening for maternal depression and screening in pediatric settings and obstetrical settings. And so while screening certainly improved the detection of depression, this is a slide showing some data from a really systematic screening effort in Connecticut involving 2 hospitals and 2 federally qualified health centers, where we screened women for depression and then looked across 6 months to see if they engaged at all in any mental health treatment. And we had a really low bar for engagement in treatment, which was just 1 visit. Nationally, we see about, for adults with depression, we see about 33% engaged in mental health care. You can see we didn't move the needle on that with our screening efforts. So we actually didn't change outcomes. We didn't change engagement in care. But I think what's really important about this slide from an equity frame, again, is we did all of the traditional things we often think about in terms of reducing barriers to entry into healthcare. So we offered transportation, we offered childcare, we offered snacks, we offered multilingual services. We started actually paying mothers to come to treatment. So we paid you $25 to engage in treatment. And even with all of those ancillary supports, we still didn't move the needle. So this was really suggestive of thinking about innovation in the way that we delivered care and also the way that we even constructed our care in the first place. So that brings me to the creation of the Moms Partnership, which we started in 2011. And to really go back to the comment on trust, it took me 11 years of working in this community to actually be able to get to this point where we had garnered enough trust to think about mental health. So we talk about moms as a bundled approach. And so we have a community collaborative. So we have this cross-sector collaboration that includes child welfare. One of the biggest barriers we heard from mothers to engaging in mental health care was a fear of removal of their children from their care. We use core programs that I mentioned that are rooted in what we know from the science. These programs are mentioned at the bottom. So our stress management is the way we talk about depression. We talk about stress, and that's cognitive behavioral therapy. We have a attachment-based parenting program, a job readiness program that also uses cognitive behavioral therapy specific to mothers with depression, and then a wraparound coaching framework. And in addition, so these are the really core programmatic elements that in any replication we maintain, but we also use location of all these elements in community settings. And so in settings that are inherent in terms of producing social capital in communities. So we're delivering these interventions in supermarkets. We're delivering them in after-school programs, boys and girls programs. We're delivering them in libraries and public housing complexes. And we're doing that with fidelity and all the while measuring fidelity. Another real key component of the Moms Partnership bundle is community mental health ambassadors. And this is the use and employment of mothers from the community that we're in, not only in providing outreach engagement, but also in delivering the services. We have a wraparound referral program, and of course, all of these interventions are actually delivered in a group setting, which was not in line with some of the literature for people that have highly comorbid, co-occurring anxiety, trauma-related disorders, but actually has been one of the key components to producing that social capital that's been so critical. So not surprisingly, when you deliver these elements with high fidelity, you see reductions in depression. But one of the ways that we begin delivering this bundled services and the way that we first engage with a new community is actually conducting a goals and needs assessment. So it's a representative sampling of mothers, of female caregivers in a certain geographic location. And this needs and goals assessment is conducted by community mental health ambassadors. So it does include some of the standard psychometrically valid instruments to assess mental health, but also importantly includes questions that mothers themselves have told us are important. So one example of this has been around diaper need. So we heard repeatedly from mothers that one of the barriers to their own mental health and their own sense of competence as a parent was their inability to change their child's diaper as often as they would like. And that programs like SNAP and WIC and TANF didn't provide diapers. So we actually started measuring and quantifying diaper need as part of this goals and needs assessment in many places. And community mental health ambassadors, again, are delivering or administering this goals and needs assessment using a model. So they're conducting outreach and engagement, delivering this needs assessment, but also importantly, delivering services, co-delivering mental health services with clinicians. So this model of task shifting and task sharing, which we borrowed from a lot of the global mental health work, people like Vikram Patel. And these are just examples, as others have talked about, really the importance of geocoding and looking at geospatial regressions with some of our data. So when we conduct goals and needs assessments, we're mapping our data. We're trying to overlay certain areas and patterns of need. We also work closely with our community to then share the data, work on local community advocacy. This is our example with diaper need again. We were able to look at diaper need by neighborhood, in New Haven in this case, work with our local diaper bank, and then also publish our findings to really add to the academic discourse on an issue like diaper need and maternal depression. So in this case, in our article in Pediatrics, diaper need was actually the largest predictor of postpartum depressive symptoms in our population. And that's when we accounted for food insecurity, housing instability, a number of the usual suspects. So just to highlight at a high level some of our outcomes here with the work, so administrative data has been really critical to thinking about our outcomes, again, when we're aligning health and mental health and social and economic mobility for families. So using some methods, quasi-experimental methods with matched cohorts, we've seen tremendous results in terms of engagement in mental health care through the MOMS model, again, reduction in depressive symptoms and parenting stress. But what's been important is this finding around attendance. And so one of the markers that we heard from a number of communities we were working in was this problem of chronic absenteeism. And so children of depressed mothers were much more likely to be absent from school at the younger grades. And so we were able to, through data sharing agreements with the public schools, look at our impact on chronic absenteeism. And this finding on working 15 or more hours a week was also, critically important to us. But that finding also relates to the last bullet here, where families talked about, meeting their ability to meet basic needs. And what that meant was actually for families telling us about how often they were pawning goods or buying goods at rental locations, all kinds of variables that we wouldn't have thought to measure had we not really talked with mothers and had them design some of the questions with us. We've conducted randomized cluster designs in public housing where we've looked at the MOMS bundled model as compared to a standard model of cognitive behavioral therapy and seen, impacts above and beyond a standard cognitive behavioral therapy, really suggesting that the MOMS model is increasing engagement and also increasing effect size in terms of reduction in depressive symptoms. So thinking about the challenges and opportunities, obviously the need to optimize programs and cross-sector collaborations around maternal depression. One of the ways that we're doing that now in MOMS is to partner with government agencies. So for example, integrating mental health delivery and services in TANF systems. So actually here in Washington, D.C., we are now collaborating with the Washington, D.C. TANF system to deliver the MOMS program. And again, keeping those core programmatic elements, but also having a local adaptation that begins with a needs and goals assessment. Thinking about, we are looking at moderators and subpopulations. An example of where MOMS is not working well is with grandmothers raising very young children, infants. So we are not seeing large effect sizes in that population, probably due to other comorbidities that we're seeing, but still the jury's out. We're very interested in aligning the human service sector, so not only through TANF, but also through programs like SNAP and WIC. So one demonstration we've done is to think, can mothers receive work credit, TANF work participation credit for participation in mental health or parenting programs? Can mothers receive public housing community service for participation in mental health programs? And this obviously requires alignment of funding sources. We will soon announce 3 other partnerships in other locations with human service programs where we have a demonstrated alignment of funding sources. And I think the other piece of this is we had been really honored to participate in a Pay for Success investigation in the state of Connecticut to think about novel financing mechanisms, so Pay for Success, or commonly social impact bonds. And as part of that exercise, really had to think about quantifying the spending, and also importantly, the outcomes that could be obtained from administrative data, particularly to maternal depression, and the challenges that existed with that when you're thinking about a multi-generational system and outcomes. So one of our largest challenges was demonstrating that there was a cost effectiveness that could be had when we implemented the MOMS program. And so there was certainly a social good that government leaders and policymakers acknowledged, but actually the ability to quantify savings across systems. So could we quantify that savings in child welfare and in Medicaid and in TANF? So even when we had appropriate data sharing agreements in place, our ability to actually be able to do that was challenging. So we were able to actually put together this model that still really drives a lot of our engagements with other government partners. And can we, at the onset, create data sharing agreements that allow for us to look at data in this manner? So I think, as others have said before me, want to certainly acknowledge our funders, and also importantly say that I have the honor of presenting to you today, but it's definitely a huge effort of staff and our partners and government and families and mothers. And more information is also on our website there. So thank you.